بسم الله الرحمن الرحيم. أولا أشكر الإخوة المنظمين لهذا المؤتمر. I would like to thank the organizers of this conference for their generous invitation and giving me the opportunity to speak. This is going to be وين التحريك هنا؟ نلبس النظارة. This is going to be introductory presentation of relevant points intended to stimulate discussion and raise interest in research. So it's not a comprehensive introduction. The importance of planning and staging always in anything, but particularly in cardiac surgery and in this field of assist devices and heart failure. My interest in this subject goes back to early 1980s. After establishing the cardiac surgery program in the Prince Sultan Cardiac Center in Riyadh, which was a department in the military hospital, the first surgery was April 1979. Then planned neonatal and pediatric cardiac surgery and started August 1982. After that, we started the planning for heart transplant program, adult and pediatric. Supported by a trained team of cardiologists, anesthesiologists, nurses, technicians, and laboratory specialists, I performed the first heart transplant in February 1986 on a 2-year-old girl. The donor was 9 months. We were ready for adult and pediatric, but it so happened that the first one came was pediatric. The success brought with it the government and community support to help start artificial heart program. I went with an anesthesiologist and a technician to Salt Lake City to experiment on Jarvik 7 total artificial heart. We acquired that in the same year, 1986. Unfortunately, the FDA passed a moratorium on the clinical use of artificial heart in that same year. We then moved to LVAD, acquiring thoracic, it's written here wrong, it's not thoracic, thoracic pneumatic device and Biomedicus centrifugal device. We should learn from the perseverance and the endurance of the others, and we should continue to do that. The initial work on artificial heart started in Cleveland late 1950s by Koft, then in Salt Lake City by many, including Jarvik, but the first implanted LVAD was in Houston by Crawford, then DeBakey. In the early 60s, several implanted, only one survived. 1969, Denton Cooley implanted the first artificial heart in a human, assisted by Liotta. Liotta was interested early in his life in the artificial heart, and he was in Salt Lake City and then moved to Houston, and Crawford and DeBakey used the assist device, and Cooley implanted the total artificial heart. The patient died in less than 3 days, raising a lot of controversy, which still exists around the artificial heart because of result, leading to more interest in the use of LVADs. At the current stage of circulatory failure management, maximum medical therapy should not be considered the end point for treatment. Mechanical circulatory support should be considered. The first line is the intra-aortic balloon pump for obvious reasons. It's a widely available, low risk, less invasive, and easy to use. The current guideline support the use of intra-aortic balloon pump in cardiogenic shock. Intra-aortic pump improve cardiac performance, but it cannot partially or completely replace the cardiac function. The second line is veno-arterial extracorporeal membrane oxygenator. The summary of indication for use, we can put it in a few lines. Shock persisting despite adequate intravascular volume, inotropic support, and vasopressor support, and the use of intra-aortic balloon. Contraindication for ECMO, sequential organ failure assessment, SOFA, score of more than 15, considered as a contraindication for veno-venous ECMO, but this same should be considered for veno-arterial ECMO. This is one of the methods. There are other methods to evaluate, and this score evaluates the state of the organ dysfunction, but it is not for a prognosis. Method of LV decompression if needed for ECMO, because patients on ECMO may have LV distension. So these methods, transseptal LA decompression or left ventricular vent or use of peripheral VAD. The center should be familiar with these to use if needed. Venous arterial ECMO risks. Upper body, it has many risks. Upper body hypoxia, left ventricle dilatation and pulmonary edema, RV dilatation and systemic congestion. RV problem is always for cardiac surgeon, whether in this specialty or all cardiac surgery. And systemic congestion is related from the RV failure. Air embolism, thrombosis, thrombocytopenia, bleeding, lower limb ischemia. But in spite of the limitations and the risk, veno-arterial ECMO remains one of the important modalities in the treatment of acute cardiac failure, with a special attention to risk management. I would like to repeat here that the importance of experience of the centers using these techniques for treating cardiac failure. Using veno-arterial ECMO for cardiogenic shock and cardiac arrest as part of the management, patients survived to discharge improved between 2012 and 2016, which is a significant improvement as presented by the Extracorporeal Life Support Register Society. This improvement is mainly because of the clinical experience, selection and management, rather than in technology, which also improved. Percutaneous LVAD and RVAD, example, tandem heart, which is a centrifugal pump, and Impella, which is axial pump. There is scarcity of evidence to support its use. Still, it should be considered in the management of acute cardiac failure. As we can see, these equipments always carries a problem of use and result, but unfortunately you are facing a problem with a patient who is heading to death if you don't support him. The long-term implantable LVADs, refined technology, this is the fourth and probably the most advanced treatment. Refined technology of the non-pulsatile continuous flow pump produced better result than the available pulsatile pump, leading to increase its use over the last 10 years. Continuous versus pulsatile from the Intermac registry, 2006, 20% only continuous. 2013, 96% were continuous. The better results of implantable continuous flow device encouraged centers to significantly increase its use. Those who are old enough, probably I am the oldest person in this crowd. Those who are old enough to remember the same discussion and research was done on cardiopulmonary bypass during the 70s and 80s about the pulsatile and non-pulsatile flow. Type of implantable pump. The axial flow, which is the rotating element supported by bivotal mechanical design. Example, HeartMate 2, Heart Assist 5, Jarvik 2000, and Encore. Centrifugal flow pump, which is not supported by any mechanical element, which is floating, supported by magnetic field. Example, HVAD, DuraHeart, HeartMate 3. HeartMate 3 is still experimental. And then the mixed flow. The complications of LVAD: bleeding, infection, thromboembolism, cardiovascular complication, device malfunction, and RV failure. Again, we should emphasize the importance and the risk of RV failure and its management. How can I go back? No, go back. Back. LVAD word experience, we just get one example, which is the mostly used HeartMate currently. HeartMate 2, FDA approved for Bridge 2008 and for Destination 2010. Most widely used, more than 22,000 implanted until 2017. The longest supported patient was 10 years. So it's a big advance. It is a bivotal bearing technology, which is prone to thrombosis and wearing. With it is the device dysfunction. So refined new technology based on magnetic levitation without bearing support expected to do better than that. Data standardization is very important because this is the only way to improve not only the technology but the clinical use of technology in selection and in the management. The Interagency for Mechanically Assisted Circulatory Support, Intermax Profile and modifiers provide a useful method to standardize evaluation of outcome of patients requiring mechanical circulatory support. Stabilization before the LVAD is very important, and pre-LVAD stabilization by extracorporeal circulation support improve outcome of a long-term LVAD implant. That has been observed when it was used for a more sick patient. They noticed that those patients do better than the other ones. So results of Intermax reported 2017. The reports to Intermax is voluntary, so this does not include all, so may not be reflecting the real accurate results. 2,200 patient overall survival, 80% 1 year, 70% 2 year, which is significant improvement on the past. Significant mortality risk out of that registry: perioperative Intermax profile 1 and 2, renal dysfunction, RV failure, and postoperatively multi-system failure and RV failure and stroke. The quality of life, Intermax report improvement of quality of life after LVAD implantation maintained for at least 2 years, measured by objective and subjective method in different places. Echocardiography is very important. These centers must have experienced echocardiography service. And as you all know, echocardiography depends on the readers. So it's reader dependent. So these centers should have a very good echocardiographers specialist, because a lot of decisions will depend on that. Quality assurance decision-making process should include all people involved in the management to consider available options without unnecessary delay. Improvement of guidelines and protocols using information from international database, from organizations like ELSO and Intermax and others, establishing specialized centers to ensure adequate experience, because these systems they need a lot of economical support and manpower. We have to look into research frontiers in this area, which is a very important to advance this technology and is still open in many points. In arterioventricular ECMO, improvement in cannula design to reduce risk. Also, improved technique of afterload reduction. The development of minimally invasive L venting for LV decompression. These are still under development. Also, for ECMO, more work on pathophysiology to reduce morbidity of ECMO, and as you remember or read about, a lot of work done on cardiopulmonary bypass in the 70s and 80s regarding pathophysiology of the circulation, of extracorporeal circulation. More clinical research to establish best practice guidelines and should be based on facts, and here is the importance of the registries, different registries. Bleeding and infection are the most common complications of long-term mechanical circulatory support devices, according to the 6th Intermax report. To reduce infection, this is in other areas of research, improve drive line design and implants technique, and also improve transcutaneous energy transfer system. To reduce bleeding, work on less invasive procedure, understanding of blood device interaction, improve the added pulsatile function to the continuous flow to reduce complications. Right heart failure is one of the difficult areas, as we said. Continue research on RVAD development and more clinical research on dual LVAD, to use it for LVAD and RVAD, and total artificial heart technology improvement. Preload and afterload, it's always these machines, very difficult for these machines to feel the preload and the afterload problems. It has to be clinically assessed by the people attending. So development of pressure and flow sensors to provide the feedback mechanism to the pump system will help to improve that. There's a need for more global randomized trials of high quality for the clinical use of these modalities of treatment. Currently, it's all voluntary reporting, and there is not enough randomized trial. Reporting mechanical circulatory support data should be made compulsory. It has been very useful, like Intermax and ELSO, but so far it is voluntary, which, as we said, does not reflect the real situation. Ethical issues always come when a discussion about artificial heart or even heart transplant. Patient selection for short and long-term use of these devices will remain difficult until more standardization of use based on evidence through proper data analysis. Dear colleagues, and I probably can say maybe I am the older person of this crowd, so when I say young means all of you. You are lucky to be in the field of medicine to serve humanity. Research is your tool to make progress. Keep in touch with the basic sciences. Don't leave it away after you graduate. All major advances in medicine and surgery achieved by multidisciplinary teams. So be a team worker. Thank you.